Welcome, everyone, to the Transformation Nurse Academy podcast. This is our weekly episode, Talk with Kevin, where we cover topics for all nursing fields with extra emphasis on emergency and critical nursing. Get ready for candid discussions that explore the vast landscape of nursing and beyond.
Welcome, everybody, to the Transformation podcast. My name is Kevin, and I have the famous, I know you don't believe this, but Dr. Lisa Wolf. Can you introduce yourself, ma'am, and just tell us about who you are, where you've been? I got all my notes and stuff, and then what is your relationship to the Emergency Nurse Research Institute?
Yeah, so I am Lisa Wolf. I am a emergency nurse of, 20 something years. I have been a staff nurse. I've been an educator. I've been a manager. Hated that. And now I am a researcher. I'm the director of research for the Emergency Nurses Association, which is kind of my main gig. I'm also an associate professor of nursing at UMass Amherst out in lovely Western Massachusetts, where I live.
Do you like Massachusetts?
I love it.
Oh.
It is one of the best. It's the Finland of the United States. We got universal health care. We got great education. We got...
Wait. Hold on. Let's back up here. So Massachusetts has universal health care.
We have had universal health care since 1997.
Shut up.
No,
I didn't know that. Now I got to do research. Now I got to do research.
That is, for those of you out in TV land, that is Mitt Romney's doing. When Senator Mitt Romney from Utah was the governor of Massachusetts.
Yeah. Are you surprised by that?
What?
Are you surprised by that?
Well, I lived in Massachusetts at the time, so I was kind of like, our Republican governors tend to be very centrist,
all right.
Because we don't put up with that nonsense here.
Yeah, I got you. But I'm surprised because I live in California, and guess what? We don't have.
Yeah, I know.
And we have a, I'm not trying to be political, but we have a Democratic supermajority, and they still can't get it done.
Yeah, we've had, everybody's has access to healthcare on the exchange, right? Some exchange in some version or form since 1997. And that's been, just to sort of bring that back to nursing, that provides a floor, like a medical floor that allows people to get care. And so our life expectancy, we were the only ones who went up in, whatever. So
I like that though. That's good. Do you know how much I pay a month in healthcare insurance for me and my family?
How much?
Are you sitting down?
I am.
$3,000 a month.
Good God.
That's right.
Exorbitant.
It is. That's crazy, right?
Do you get that through your job?
No, I have to pay that on my own.
Oh, wow.
Right. Yeah. That's why I'm working. That's why I'm up at 5 o'clock in the morning.
Right. Well, I think that's another piece of it, just sort of structurally, when you tie people's health insurance to an employer, right? That becomes, a discrete employer, that becomes really problematic for a lot of people. And it really discourages innovation. It discourages people starting businesses. It discourages all the things that people say they want in an economy, right?
I agree because I'm passionate about this. I don't know. I don't want to get in trouble. I don't want to get you in trouble, but I do ask that question. I'm not a fan of them, but if you are, I understand. But like the American Nurses Association, all these big associations, I'm not talking about the ENA, but talking about all these other nationwide ones, all the unions and stuff, how come they don't have a way that nurses can buy into health insurance more affordable and have it available all across the board so it's not tied to our job? So nurses can do whatever they want. That's what I don't get.
I agree 100% that would be, those organizations are big enough. But I had this really very recent, very interesting conversation about nursing organizations with somebody. And sort of the bottom line is that nursing organizations, like all other large entities, are inherently very conservative.
Right? You think so?
I do.
Even the ANA?
Yeah, because because when you have a really broad constituency or membership, right? You've got people across the political spectrum.
Right.
And you you don't, the challenge then is, how do you do what's objectively good without pissing off half your
Right,
membership,
right, right. I
right? Who
get you.
feel like that's socialism, right?
Right,
And those folks are really loud, and and I've encountered in my work at ENA. There's large swaths of the nursing. Nurses are people, right? And they
right.
kind of cover what's really interesting, I think, is that a lot of the research work that I've been doing lately kind of points me to this thing, which is that nurses focus on the nurse patient relationship, right? So anything that happens outside that relationship, they see as none of their concern. And this kind of comes from this great paper, highly recommend. Evelyn Barbee, Barbee, 1993. She's an anthropologist, comes out of Boston College, and wrote a paper about racism in nursing specifically. And this idea applies, I think, to a lot of things, not just bias and racism and discrimination, but this idea that nursing as a discipline focuses on this very one-to-one relationship and discourages bigger thought, right? Like what
Right.
you're talking about, like, why don't we organize? Why don't we provide our members with these important, what we already know are important benefits? Evidence suggests that people who have insurance get better care, right? So why
Right.
would we not do that? So there's this conflict avoidance. There's this very heteronormativity, right? So like everybody wants to, nobody wants to stick out, right?
That's
And
true.
and this idea that the nurse-patient relationship is the only important relationship rather than the lateral professional relationships that we need to build, right?
Right.
Does that make sense?
No, it does. I talk about it all the time. I get in trouble because I teach too, just not as fancy as you, but uh I talk about conflict avoidance, and I don't, maybe I'm sexist, but nursing is dominated by females.
Mm-hmm.
But a lot of females that I've dealt with and saw, and I say observed, don't be mad at me, but I observed you creatures for the last 30 years. You don't like conflict, and I don't know why. Like, I'm not trying to cause trouble, but if people aren't doing what they need to do for us as a whole, then we can make things better. Why don't you stand up and talk? But
Because
for
women
some
aren't
reason,
allowed
people,
to be angry. Women aren't
why
allowed to
not?
be direct, right?
Why not?
This is a
I
cultural
liked it if you're
pressure.
direct. I'd rather you be direct with me and tell me quit being an asshole than not, beat around the bush. Why not?
Right.
Why
Oh,
can't you be
absolutely.
direct?
But you're ignoring the cultural conditioning that
Yeah,
women undergo, right? Which is to be nice and don't make anybody angry. And this is a version of the doctor nurse game, right? If you're old as I am,
right.
if
I
you
got you.
recall, where you learned, like literally learned, watching other nurses to be able to say things like, hey, I'm wondering if you might think about, what if what if you tried this approach, medication, whatever? What do you think that, you might want to call your attending about this, right? And you have to make it think like it's their idea, right?
Right,
That
right.
kind of conditioning is really, really strong, both in nursing and in women, right? In the United States. And you can't ignore that. This is like oppressed group behavior in a big way, that sort of lateral violence. And, to extend that, like we did this great study about bullying, this theoretical study about bullying, and we validated it with a study of post-traumatic stress disorder and secondary traumatic stress in emergency nursing. And I am like really coming to the conclusion that a lot of our behaviors, the kind of behaviors that you're describing, are the result of unmanaged trauma,
Yeah,
right?
I
So
believe that.
yeah, I mean, we're in the ER, we are subject to this tsunami of other people's pain and distress and whatever, and like that
Right.
does stuff to you.
Yeah,
Um, and so everybody kind of wants to stay under the radar and just kind of keep doing what they're doing and keep their peace and like chill and maintain. And calling people out on their bullshit, it disrupts that.
yeah. Do,
It
do you
becomes
think it
really
makes,
challenging.
do you think it brings up anxiety or angst to call somebody out? Or do you think, like
Sure.
you say they stay in their place because they don't want to, make the waters ruffle? Like, is it
Right. I don't
because
think
it's a
anybody wants
comfort
to rock
zone?
the boat. But I found out in this like study I did way back in like 2009, it was the study before my dissertation study. And it really became apparent that that the social pressure, the culture of a given emergency department really affected how people communicated about patients, right? So think about when a new nurse comes on in your emergency department, right? And they come to either the charge nurse, they come to you, and they're like, "Oh my God, I think this patient is really sick." And the first thing that everybody does is like, calm down,
Right.
nobody runs here, like get a grip, right? When in fact, the patient might be really sick. But
Right.
we teach new people to disregard
Right.
those red flags because
Right.
we don't
We
run
don't
here,
want you to get
right?
excited and
Right, don't get
okay.
excited. So that social pressure really, so the next time somebody who's really sick comes into that nurse's room, they're going to hesitate before
Right.
they go and be like, "Hey, there's something, I need your help," right? And so we condition each other to do that. So the social pressure to conform to whatever the culture of the ER is really inhibits decision making, right? Because the end result of a clinical decision is an act, it's
Right.
not a thought. And so the challenge is to get those thoughts out of people's heads and into action. And if we teach them not to do that, then we can't be surprised when they don't do that.
In fact, we get mad at them when they don't do it.
Yeah,
Yeah.
it's
I just had
gaslight. It's
this
like huge gaslighting.
right. Well, I just had this happen because I left the bedside for 4 years because I needed a break, but I just went back. And in this last week, I won't tell you the doctor's name because I don't want to be in trouble, but um, sh we had a patient come in and she said the patient was hypokalemic, and I looked in the labs and the potassium was like 5.3. I'm like, okay, but it's not that high. And she wanted to treat it. She wanted to give D50 and calcium chloride and insulin. I'm like, really? I said, and I did what you just did, even though I'm not scared to confront doctors. I did what you did because I'm new again and I don't want to cause trouble. But I walked up to her just like you did, and I says, doctor, I'm not sure, but why are you treating potassium when it's only 5.3? I've never seen anybody treat it like this because I don't want to cause trouble because I'm just back again. But she's like, well, just in case. And I said, just in case what? Well, she is a dialysis patient and her potassium might go up. I'm like, okay, but it isn't up, so I never heard of such a thing. But other nurses were like, oh, Kevin, that's Dr. So and so. Don't piss her off. I'm like, I don't give a shit. I said, but you're treating somebody inappropriately. That's not, it's our duty. We have an obligation to speak up. You can't just let people do whatever they want just because they're a doctor. So I get you. But I did, even myself, I found myself trying not to be too confrontational because, I don't want to rock the boat too soon because I do have a mouth on me.
All
So,
right. So, I mean, you want to, like anybody who's listening to this, like you want to, next time you get into an interaction where you're challenging somebody's decision or questioning somebody's decision, like pay attention to how you feel about that. Because we all
yeah,
like to think, "Oh yeah, I'd speak up," right? But no, not so
yeah.
much.
Well, I mean, I'll speak up. I don't mind it, but I didn't want to rock the boat so soon because, it is only day 3 back because,
I'm
I
telling you,
do.
like what you see is what you get, right?
Yeah. All right. So how did you become interested in emergency nursing and what has kept you engaged in this high stress field?
Yeah. So when I was in nursing school, which was a second sort of go round for me, um, I was
What does that
at
mean? What does that mean, second go
so
around?
yeah, so I graduated from college with degrees in anthropology and
Yeah, I saw that.
medieval English literature.
Master of
I
Fine Arts. She's got a Master of Fine Arts
have
in
a Master
creative
of Fine
writing.
Arts in
And then it
playwriting.
says Amherst College Bachelor's of Arts in Anthropology.
Yep. Yeah.
I
So I
thought
was,
that was a spoof account, but I guess it's not, huh?
it is not a spoof account. I'm actually ridiculously overeducated.
No, I love
Um,
it.
so what I found, having gone through 6 years of post high school education, was that I didn't really like working as an administrative assistant, which was about the only thing available to me at the time. And so I got to work. I got a job in women's reproductive health in
Oh,
Boston.
all right.
So, which was exciting when you're 22 or 23. And what I really found importance was the nurses, right? So I worked as a counselor, I worked as a recovery room nurse, a medical assistant at the time, right? So I was an OR medical assistant, I worked in the recovery room. And what really impressed me was these women who were coming to us seeking reproductive care, including abortion. Really, the nurses met them where they were, right? They really walked them through a compassionate but solid decision-making process. They supported whatever their decision was. We went through the procedure with them, we recovered them, and the nurses were like clinically, relationally, just it was amazing to watch, at this really pivotal moment in our patients' lives where they were for the first time regaining control over what was happening to them.
Right.
And I was like, I want to do that. So I wanted to so I applied to a bunch of nursing schools because I had all these degrees already. I applied to all these 3-year NP programs, which were just starting up in the 90s. And
right.
I got rejected from all of them because they took like, I don't know, 5 students or whatever. So up the street.
Do you think it was because you're a woman though?
No, I think everybody applying for these programs was female.
Oh, I got you.
Everybody. And so I ended up working for a architecture firm in Boston as an administrative assistant, but they paid me more. And they built hospitals. And so I found out like literally up the block from where I lived was a hospital-based school of nursing. And I'm like, I'll apply there. It's easy to get to, right? So I did. And so I spent 2 years in St. Elizabeth's Hospital School of Nursing. To be a midwife, actually. I really wanted to go into women's healthcare. And then I did my L&D rotation and realized that would be an incredibly bad decision for all.
Why is that?
Because I didn't have the patience.
Like you mean you didn't have the patience? Like
I did not have the patience to sit by somebody's bedside for 8 hours while they labored. I would have gotten bored. I would have been terrible for the patient, right?
So but you're good at OB apparently.
Well, I've returned.
You have evolved.
I've evolved full circle back to OB and the ED.
All right.
Yeah. So, but then I did an emergency department rotation in my senior semester, and I was like, "This is it. This is the thing I want to do." And they were like, "Well, that was back in the day when you had to be in med surg and then go to ICU, and then maybe if somebody died, you could get a job on nights in the ER." So I was like, all right, fine, whatever. So that's when I took the research job where that first paper came out of, mostly because my whole family was in New York. And I was like, what do you mean I have to work on Christmas? Like, what is that? Right. So I took a job that didn't make me work weekends or holidays or whatever. Right. So my first job in nursing was like ridiculously easy in that sense. But I learned a lot. I learned how to talk to patients a lot, because when you do research, you spend a lot of time explaining stuff to patients, participants, subjects, whatever they are, in their trajectory. But then I moved from Boston down so I was at Mass General for my first job. I went to the Joslin, did a lot of work with diabetes and other kinds of endocrinology.
Yeah, you're a diabetic nurse at Joslin, right?
Yeah, good research stuff. Lots of fun. Learned a lot again. And then I moved back down to New York to start up the research arm, kind of administrate the research arm at Columbia. And I just, I was like, physicians who work in this type of research are not people. Like they're not.
What do you mean? They just don't like to deal. They don't like to
deal with
people.
That's why they're doing research. Right? Yeah. So I was like, this isn't working for me. So I got a job in the ICU at night in a community hospital where there were no doctors. It was amazing, right? Like in terms of clinical decision making, like this was amazing. And it's so different the way it is.
Nursing is now.
Yeah, I mean, literally, there were no physicians in the hospital at night. Yeah. We ran our own codes. We did everything.
People don't believe me when I tell them that. I feel like I'm living in the twilight zone. Don't be mad at me, but this is my feelings. I feel that we have dumbed down nursing over the last 20 years.
Absolutely.
Because when I first started, like you, we worked in ICU. There was hardly any doctors. We hardly had any RTs, if any. We did everything. We did everything on our own. Yep. Now, I can't even give a breathing treatment in a damn ED. I got to call RT.
It's very weird. Yeah. But Yeah, so I mean, I went from the ICU to the ED to the PACU to the ED. I kind of bounced around that particular hospital, but really landed on the emergency department. And then I had the opportunity to be a manager, um, on nights, and then the educator. So, that's kind of when I joined ENA because this is 2004. I was like, I should be certified if I'm going to be an educator. Um, and so from there, it's just been like all ED all the time, and it suits my attention span pretty well.
Right. So you
Um,
like the ED better than ICU?
Sometimes, like
Oh,
as I get older, I'm like, it would be
right.
really nice to have my lions labeled, right? It
Right.
would be really nice to manage this.
Right.
Um, but
I don't know if you've ever been officially diagnosed, but do you think you have ADD,
no, I
ADHD?
absolutely
No? All
don't.
right.
I just
You think
have
it's just our personalities as nurses then?
I think it can be. I think it would be really interesting to look at a number of sort of personality traits of to, what suits people to different specialties. I think we all intuitively have some idea, but it would be really interesting to quantify that.
Right. Because I love the ED. I was a trauma ICU nurse for a long time, and then I never really thought about the ED because I was a combat medic. I spent 9 years as a combat medic. And then people always ask me, well, how come you don't go back to the ED? I'm like, I had enough of that stuff. I like the
Right,
nice, slow pace. I only got two patients.
right.
But then I took a travel assignment, got back to the ED, and I got bit by the bug again. I haven't left since. So
Yeah, it's like a bad boyfriend.
it is. I tell it's abusive relationship. So I love this about you because this is on your what I thought was a spoof profile. It says you said teach nurses how not to kill people. Now I will say this before I finish reading this. You hurt my feelings this morning. I had a little meltdown and cried a little bit because you already have another Kevin in your life, and I don't appreciate the hell with you, Kevin McFarland,
I
son of a
do.
bitch. I know, but it's
I
okay. So
do. Yeah, Kevin and I are podcast buddies.
I know I love it. He's the one who taught me how to do this. So, all
Oh,
right.
amazing.
Yeah. So it says, you have on there, teach nurses how not to kill people. So can you elaborate on that? Because I love that.
Yeah, well, that's the job, right? So I've been teaching since 2003 in various adjunct or
Right.
full-time academic positions. And I think what's really important for new nurses, like of any stripe, right, is to understand like nursing is a deeply ethical endeavor, right? It doesn't have to be a calling and it doesn't have to be this like religious moment or anything, but
Right.
like the job is you protect people, right? You
Right.
are the firewall between your patients and death. So, um, so to teach nurses how to approach patient care in a way that minimizes and mitigates cognitive errors that lead to poor patient outcomes,
Right.
right, and up to and including death. So things like you know the idea of you have to keep following the line of inquiry, right? Like you can't just decide what it is at first, with your eyeballs, right?
Right.
We can have a pretty good idea, but we know that like experience doesn't equal expertise. Like
Right.
you could be doing it wrong for 30 years. We see that all the time.
Wait, say that again. Say
What's
that
that?
again. Say it one more time, what you just said.
Experience does not equal expertise.
Yeah, but keep going. You could
And
be
we all
doing it
know
what?
people who've been
30
doing it
years and you could
wrong
still be
for
doing
30
right.
years. Yep.
Well, because people do that all the time. They say, well, that's the way we've always done it. And I'm like, yeah, but is that the damn right way? Like,
Right, exactly. And
that's
so as a
craziness.
researcher, I become really obnoxious in that way,
I like it though. We need you.
Well, how do
Right.
you know it works? Right? Like
Right.
that's my favorite question, and that's the one that gets me kicked out of parties. How do you know that works?
But I like that though. It's a valid question because if we're not changing, medicine changes it all the time. So if we're not questioning it,
Right,
I mean,
right.
but
And
I
so that was
think,
kind of the impetus for the How Not to Kill Your Patient
oh,
podcast. Right? Was
uh,
like we needed to give people little truth bombs,
right. I
that they
like
could
that
listen
though.
to
Yeah.
on their way to work.
But I like that though. It's true though. All right. So,
Mhm.
what is the primary focus of your research at the Institute for Emergency Nursing Research?
Yeah, we don't have institutes anymore. It's just the emergency nursing research department.
Oh, it's not called that anymore?
No, it's not called. It hasn't been called that for like 5 years. I know.
Oh, well,
Um,
it's on your LinkedIn profile.
I know. You see how technologically competent I am,
It's
right?
all right. I love it. So it's just called Emergency Nurse Research.
Yep.
All right. Fair
That's it.
enough. So
So
what is our
what
primary
what
focus?
do we study? Yeah. So what it kind of goes back to this idea of how the environment affects nurses' ability to function fully, right? So we right now we're doing, I wrote like 8 papers over
It's
Christmas
okay.
break. It's like nuts. Um, but
Listen to
we
her 8 papers over Christmas break.
I know it's terrible. That's what I do when I don't have any meetings. I write. But we're doing right now, we have papers out there about frailty, how emergency nurses understand frailty, like what's their conceptual understanding and when would they use like a frailty tool. We have stuff out there about risks to people doing research in the emergency department. Um, we have a paper out about a new trauma course, a Delphi study about, what should go into an advanced trauma course.
Well, I would
Um,
ask you a question, but I don't want to cause trouble. But I do have a really serious question that
yeah,
maybe
shoot.
you'll answer off air, but I don't want to get in trouble.
Oh, okay.
Because because something just happened. Because I teach TNCC and I sit on the committee, with I do a lot of I do things on the backside of the ENA
Yep.
where I sit on all these committees because I like to learn. It helps me learn and stuff. But with the new ninth edition TNCC, I don't know if you know our relationship that we had with somebody for 30 years is over.
Mm.
Did you not know that?
Well, I don't, that's not really my part
Right.
of my job. So
I
I
got you,
think
but that's why I want to know what happened to that relationship and what is it that we did that caused them to break up with us. But nobody will answer that damn question.
I'm afraid I can't answer your question either because
It's
I'm
all right,
not
but at
familiar with
least you'll
this
know
particular
now what I'm
problem.
talking about. All right, anyway, go ahead. I didn't mean to interrupt you.
Yeah, yeah, no, that's
So
okay.
you said frailty, risking the ED.
Yeah,
What else are you
advanced
doing?
trauma.
Advanced trauma. So is it a new class that we're going to be bringing
Yeah,
out? Oh,
yeah.
that's nice.
Charge nurses, charge nurse curriculum.
I like that because we don't. That's one of my big pet peeves is that we have charge nurses and managers, but they never get training. They just
Exactly
get
right.
thrown in there and they don't know how to lead and shit.
Right. So
And
we
they
did a
just
couple of
flail.
studies. Yep.
Yeah,
Did
they
a couple of
flail
studies
around
about
and
what should be in there and how we should teach it and how we should evaluate it. So that paper I hope will come out soon. We just did a paper on freestanding emergency departments.
right.
So what we're really looking at is like what are the conditions under which emergency nurses need to function? How does that impact the way they're able to take care of patients? And how do we make that better?
So one of the things that I fell in love with you about, because I got to be a part of your research, was the OB emergencies in the ED.
Oh yeah.
You were part of that, right?
Mhm.
The one that was with the I don't know if I'm saying it right. Is it A1?
Oh yeah, yeah, yeah.
It was in conjunction with A1. It was the big
Yeah,
long
yeah, we're
class.
writing that up right now. Yeah.
Yeah, so I love that because I think that's our weakness in the ED because we have this magic number where a patient comes in, they're 20 weeks, and we send them upstairs and we just ignore them.
Yeah.
But we're
And if
nurses. How come we
yeah.
can't
And
take
if you
care of
don't
these
have an
patients?
upstairs, they're yours.
Right. Well,
Yeah.
what if they can't go upstairs because upstairs is busy and full and backlogged like we are? So we're nurses. Why can't we learn how to do this?
Right.
So that's why I really like that. I really like that program.
Yeah, it was
So
hugely important because there are, and I think where you are is an obstetric desert or
yes, we
very
are.
near
We're in the
one.
OB desert. That's right. That's why I'm passionate about it.
Right. So
Yeah.
yeah, so I think I'm going to say about 400 nurses took that course. So we're
When's it coming
evaluating
live?
kind of what
When's it
that
coming
looks
out
like.
live to everybody?
Yeah, right. Well, it's a very expensive course. We got
I
grant money.
know. I know. I know. I know. I know. I saw it and I was like, ooh, I'm lucky. Yeah, it was good. So, let me ask you this. How does your research work translate into actionable improvements in practice in emergency nursing?
Yeah, well, so I think the benefit of being situated at the ENA allows that knowledge to be translated much faster potentially, right?
Right, I get you.
Um, so the research that we did on the trauma course, right? That's being built right now. The charge nurse study that's being built, or will be built once the paper's published. Um, we're doing some stuff around triage, competency verification, right? Again,
Right,
like
right.
research piece that translates into an actual thing. Point of pride, a study that I did with a couple of collaborators. including my daughter, who's an anthropologist,
Oh, look at that. That's nice.
was published in the Gen. It was about how emergency nurses in states with abortion bans navigate obstetric emergencies,
Right,
and it
right.
did that through UMass. But that study is cited in the National Council of State Boards of Nursing report.
That's nice. I like
And
that.
I was
That's
like,
yeah, that's good.
yes,
Yeah.
like
Well, because
finally,
we got to put you on a bus to take you somewhere else so you can get taken care of. That's
right,
crazy. Yeah.
exactly. It's crazy. It is crazy.
Yeah.
But yeah, so there are certain things that are like really immediate impact, and part of the reason that I have had this really great job, right, is that there's not a lot of emergency department situated researchers
Right. There's
because
not.
it's
Right.
chaotic and it's crazy and like you can't do a randomized controlled trial, right? So the space is kind of empty, right? It's like
You're
crickets
like
here
a
in the
unicorn.
space.
Right.
So the group of people that I write with and work with, the advisory council, are all volunteers, just like the work that you do when you're working with ENA. But they're probably 2/3 of like the people who are actively doing ED centered situated research in the country. So like we have this really prolific group of really smart people, and we can kind of bang through a lot of problems.
I got you.
Um,
But do you do the research at their facilities? Like
no,
what facilities do you go to get the data and the research?
well, yeah, so that's a challenge as we move toward, more implementation type of studies.
Yeah,
So
because facilities are very resistant to
yes,
change.
yes, they are. You'd
Yes.
be surprised.
Oh no, I'm not because I live in the Central Valley here and they do not, for some reason, I try to get the E&A kind of classes into these hospitals and they're very resistant. They
Right.
don't, I'm not sure why. I don't know how
Well, part
to,
of it is like nobody wants to give data and they don't understand how research studies work and how we anonymize data and how we report out data in aggregate ways, right? So that we would not name an institution. We would, there's a lot of ways that you don't call people out, right?
yeah.
Like we're publishing a study on triage recognition of preeclampsia,
Right,
right?
right, right.
And of course, what we're finding is that we're terrible at it. We miss it
Yes.
80% of the
Yeah.
time, right? So
Yeah.
this goes back to your thing, right? But to get that data, we have to completely anonymize it. We have to just give basic, geographic regions, right?
Right.
But I would argue that it is no different. We did a very similar study through ENA at in on the East Coast at 5 hospitals on the East Coast and found essentially the same thing.
Same thing.
So
Right.
yeah,
Well,
so
I
I
think it's
mean,
because we dismiss OB. Like I said, we just dismiss because I know I'm dumbing it down, but I use one thing from the class I learned is like a lady comes in 12 weeks post delivery. Her blood pressure is 140 over 90. What are we gonna do? And as an ED nurse, I asked this to almost all my ED colleagues, and what do you think most of them say?
nothing.
Ah,
What
it's
you do
okay. We're gonna
anything?
send.
She's fine, right?
Yeah, because we don't, and I didn't know that it was a sign of pre, right? I didn't know that. I was like, oh, sure.
She's in the SI too.
Right. See,
Allow
okay, but that's
preeclampsia.
another issue is so ESI is a big issue because I don't get engaged in it, but I don't know if you know on the ENA when you are like an instructor, whatever, you're invited to this ENA Connect, and
Uh-huh.
all these people are posting their problems and stuff. And so many people ask about ESI triage, ESI this. I'm like, we have a class that was developed by probably you and or at least tweaked by you and nobody uses it where you have all these different people using these different things and we're not consistent on the same sheet of music.
That's
I
why
don't
there's
get that.
a handbook. The version 5 came out about a year
Why
ago
don't people use it then? How come
because
emergency departments are so inept that they managers won't like go there and use it? I
well,
guarantee that
the
most
thing is
managers
people
probably
people have no idea how to look things up, and
they
that's
do it, they're
this
just
is
lazy.
this is if you can find the best sushi restaurant in Missoula, Montana, you can find the ESI handbook.
Right. I agree with that. That's true. I'm gonna start using that. I'm stealing that.
We have the collected knowledge of humanity in a phone. Like,
Well, I tell people if I would have had the internet as a 10 or 12-year-old Kevin, I probably would have been a Bill Gates by now because I love the internet though, because I can find anything I want. I can ask questions. I'm not saying everything on the internet is true, but at least it gets me asking questions. I can find people like you who know the answers, or at least guide me in the right direction. So, all right. So, what are some common mistakes or misunderstandings about immersion nursing and how they can be addressed?
Wow. Well, I think in
Wait. I gave you these questions. You don't remember this?
that's broad. Um,
I did. It is. It is.
yeah, it's broad. Well, I think the big challenge is the way that we educate nurses. Um, it's changing a little bit because the NCLEX is more case study based now,
Right.
and so it's much harder to pass if you're just like memorizing it like high school French, right?
Right.
So that's a step in the right direction. That um, I think that nursing programs, and this really all starts with pre-licensure education, right? Like we have to teach this as a cognitive process, not as a
A
list of
numbers game.
facts, right? Um, there has to be much more concerted training in clinical judgment and the process, the diagnostic process, right? I think that the um, I think that people who teach in schools of nursing should have to maintain a clinical practice. I think that the way, even when I tell my students, when I was in nursing school in the 90s, uh, a patient who was admitted for pneumonia was in the hospital for 7 days,
Right.
right?
Right.
And the care plan went something like this. Day one, sit them up in bed. Day two, help them sit in a chair, like you're moving them closer to the door every day. But it was a 7 day course, right?
Right.
And now you have to be nearly dead, first of
Right.
all, to be admitted to the hospital. Like the
Right.
level of acuity is completely different than it was even 15 years ago.
Right.
And I think that anybody who hasn't touched a patient in more than 5 years really doesn't understand that as
That's
their
why I went back to. That's why I went back to the bedside because I didn't want to become irrelevant.
right. That's
Right.
why I kind of dip in and out
Right.
of the bedside as well. Um, but I think that's a big part of it. Like people are much sicker. I think teaching nurses really explicitly, there's this idea that like, oh, they'll get it, right?
But they
Eventually.
don't.
No,
Right.
no,
But
no.
they.
You have to
Right.
explicitly teach this. You
Right.
know, when I ask my students, like, so what would you do in this situation? And they're like, I would advocate for my patient. I'd be like, well, what exactly does that mean? Like,
Oh,
write it out for me.
all
What does
right. That's good.
advocacy
I
mean? And
like
they're
that
like,
idea. All right.
I don't know, right? So we toss these words around as like part of nursing practice, but we really are not giving people a good idea of what that actually means. And
Right.
often, I'm like, look, if this is something you don't feel able to do, like bail now, right? Like
Right.
you're only a semester in,
I,
bail, go, be a florist, go do something that makes you happy. Um, and even if you don't like people, the thing is, nursing is so huge, right?
right.
Even if you don't like people, you can get a
You-
job at nursing, right? Like if
Right.
you like the
You could be a
intellectual
researcher.
exercise,
You could be a
right?
researcher if you don't like people.
Yeah,
Yeah.
exactly. I'm an unbelievable introvert, right?
Are
So
you really? I don't believe that.
I am. I go to conference and I'm like, I have to get back to my room and take a nap, right? Like I work from home. I've worked from home for like 15 years,
Yeah.
right?
No, I agree. Yeah.
You know?
I'm good at talking to people, but I really don't like it. It makes me uncomfortable. And people don't
Oh,
believe that. I feel like I'm an introvert too because I can stand up in front of a room like you and talk, but I don't, makes me uncomfortable. Like I really get nauseous inside.
oh, I don't. I was in theater for years, so like
Oh,
this is performance art to me, right? But it's still kind of exhausting.
it
So,
is. That's true. Do you think that do you think that because me, I want to see that I want to have a nursing profession that can work independently, not independently without physicians, don't get me wrong, but I want us to be able to work to the maximum of our scope of practice, but we don't.
right,
Do
we
you,
don't, and
why,
that part of that is our relationship with our physician colleagues who are doing kind of everything they can to, make nursing a task-based, um,
well, that's what I teach.
profession.
That's what I teach. I'm like, we're still teaching, not everywhere, don't get me wrong, but we're still teaching a majority of nursing schools are still teaching task-based nursing and not
Yeah,
evidence-based
it's not
nursing.
cool. Not cool.
And
Like the
it
task is a means
shows.
to an end. It's not
Yeah.
the end.
But how do we get away from that? Why are we still teaching that? Because I just had students yesterday and it's a pet peeve of mine, but like the Foley catheters, you're not supposed to inflate the balloon anymore. But nurses still teach that in school. And I'm like, it's literally in the damn book that you don't do that. Do you not read the book you teach your students? Like,
Right.
so
I have
how do we,
something similar with aspiration after IM injection.
right?
Like
People still do that,
we haven't done that since 2000. Like
right? So why are we still teaching it? It's probably even in the
because
book
they're
too.
because the old nurses so this is the answer I got. The old nurses at the hospital it's still in their policy. So we have to teach it. I was like,
Oh,
we're
yeah,
the university. We're supposed to inform practice. Like, what are you
yes.
doing? You have this go backwards.
Well, I tell people that I said if your policies are outdated like that, they're still teaching you crap that's no longer valid. I guarantee you, and I don't trying to be mean, but I guarantee it's because there's a bunch of old ass nurses who've been in nursing for 30, 40 years and they never go and read a stupid book and educate themselves and they leave these old policies in
Sure.
place.
Because that's the
And
way
I
we've always done it, right?
right, that's right. And I tell the new nurses, get on the damn policy committee and make a change. You can do this.
That's
All right,
right.
so I did say this, and I know we talked about this already. So, what are some recent findings you can share about OB emergencies, and how can it be implemented in emergency department? I know it's a
Oh
broad
yeah.
question, but
All right. Yeah.
pick the
This is
highlight points that you think is most important.
okay. So first of all, we don't know anything about obstetrics, right? Second, we're terrified by obstetrics. That's why we went to the ER, so we wouldn't have to
Right,
deal with babies, right? Third thing, this is a population that is growing enormously,
right,
especially friends and neighbors. If you're in the large part of the country that has banned abortion, you
right,
are going to see large numbers of people who are pregnant who do not want to be, who are being endangered by their pregnancies, right? So you will
right,
see a lot more pregnancy emergencies. You will see miscarriages. You will see incomplete miscarriages. You will see premature, previable rupture of membranes. You will see all of those things. You will see preeclampsia. You will see cardiomyopathy, all kinds of stuff. You need to be able to recognize that immediately. And
right,
you need to be able to advocate for appropriate care for that patient, whatever that
right.
looks like where
Yeah,
you are. You need to demand information from your administration on exactly what is going to be done for these patients. Because this is where people die, right?
but
And in terms of like the most important findings is that again back to this idea that nurses are really reluctant to engage with things that they view as political,
right,
right? Nursing is political. We are
right,
at a crossroads of patient care and state legislation.
right,
We are there, like you can't ignore it. So you
right,
have to figure out how you're gonna, as a group, right? Like this is a big emergency department staff meeting with your administration. What are we doing? What are our endpoints? When do we call legal? When do we just, what are we gonna do?
right.
Right. And I think that is going to be the big opening up area of emergency care is going to be OB.
Yeah, because
Um,
people don't realize what's about to hit them.
exactly. And
Yeah,
it's already hitting places like Texas,
right,
clearly. In Idaho, for example,
right, right.
the Supreme Court there has ruled that EMTALA doesn't apply
How
to
can you
pregnant women.
overrule that? Isn't that a federal law?
It is a federal law, but
So
we
how
have
can
states who are violating the supremacy clause. Like, I don't know what to tell you. But the
right,
thing is, a lot of these laws are written in ways that are so vague that it's
right,
really easy for everybody to be like, oh, well, we can't do anything, when in fact the law may not say that.
right?
Right.
But I think
So
maybe administration are scared. I think administrations, managers, directors are
of
scared or
course
maybe even incompetent to help their staff.
I
So
agree.
how does a staff member go to somebody who's either scared or incompetent? What are we going to do to change that?
Right. I think the challenge there, or the way forward, is collaborative, right? Like it almost like they don't listen to nurses much, but they will listen to their physician groups, right? So there needs to be an alliance built if there isn't one already. Like nobody wants to lose their license. Nobody wants to kill a patient. How are we
Right,
going to navigate this? Right. This is not a case, and it's funny because in the course of a couple of studies that I'm in the middle of, nurses have said to me, well, I don't believe in abortion. I think it's great that they banned it. I'm like, well, that's fabulous. But what's coming into your ER is not people asking for elective
Right.
abortions.
Right.
It's people who have premature rupture of membranes at
Right.
18 weeks, right?
Right.
So what are we going to do about that? Right.
Right.
And they're like, oh, I didn't
Right.
realize that.
Right.
Right. So
That's my whole point. Like you're not saying you're not there during abortion. It's coming. It's but the problem I think is misconception because abortion doesn't mean that you're always that you're going and getting the baby aborted. Sometimes it's just a spontaneous abortion.
right.
It's
Correct.
coming out because the body wants to expel it because it sees it as a foreign object. And what are you going to do about it? And you're going to see more of it, like you
Sure. I
said.
mean, what nurses are telling us is that patients are being sent home.
Wait, say that one more time.
Patients are being sent home and told to return if they get febrile or if they start getting chills or some signs of infection or sepsis, because then
That's
we can
crazy.
do
That's
something.
incompetence, and that's going to cause people to lose their license, and lawsuits are going to happen. Why
Absolutely.
would you do that? That's nuts.
Right.
I
Right.
get you.
Yeah.
I
So
know
there
you're
needs to
preaching
be
to the
sort of
choir.
a big teach-in around this. Happy to
Yeah.
help. Right.
No, I love this. That's why I like it because I know that you're passionate about this. So can you consider some of the potential complications and considerations nurses should be? Oh, well, we just talked about that. You already answered that question. What is your experience and expertise? What is one piece of advice you'd like to share with all emergency room nurses? If you could give one takeaway.
Um,
I know that's a big question because you got a lot of on your plate to
yeah,
talk about.
I think emergency nurse is like the buck stops here, right? We're the canary in the coal mine, right? And all the fallout from all the societal gaps shows up for
Right.
us. And to see the work of emergency nursing not as personal, but as societal is
Right.
really important, right? I think there's a lot of nurses out there who really think that some patients deserve their care and some don't.
I was
And
just thinking that in my head. That's right.
I would ask you to abandon this Calvinist approach
Right.
and understand that you are doing the work of society. Like this is the social contract,
Right.
right? We take care of each other. If you don't feel like that's a place that you want to be, then you should go to boutique dermatology, right?
Right.
Like you should go
No, but
somewhere where you can judge people appropriately, right?
yeah,
But
I
this is
agree
not
with
the
that.
place.
Yeah, I agree because I do talk about that. So like I give my student a baby. I'm like, I'm the parent. Ask me some questions, and they ask me questions like I basically tell them nothing's wrong with my baby. Nothing's wrong with my baby. And they're like, well, why are you here? And I said, see, that right there means you're jaded already. I said, why do you give a shit why they're here? You're here 12 hours. You signed up for this. Who cares if they come in too soon? Who cares if they come in too late? They don't, people are people. They're going to come in no matter what.
And the question is not, so why are you here? The question is, what are you concerned about? Like, what are
Right,
you afraid of that brought you
right,
here today?
right.
And how can I help you manage that?
But we get so jaded though. I shouldn't say we because I love it. But people get so jaded in the ED because, you get frequent flyers that come in. But I love the frequent flyers. You know why? Because I know them, and all I'm gonna do all night long is give turkey sandwiches and cheese, and I get to talk to them, and I
Yeah.
get to know them, and maybe I can help them and stuff. So I don't understand why we're so mean, and I don't know, it's
It's like,
crazy.
yeah, if you're me and I just actually did a podcast with the other Kevin,
Oh my God,
on
I hate you, Kevin.
on burnout, right? And this
Okay.
idea that if you're so burnt out that you can't be nice to somebody who's showing because they have nowhere else to go,
Right.
leave, go
Yeah.
take a vacation, go work
Yeah.
in outpatient, go
Yeah.
work in,
Yeah.
you know,
Heck you.
go work
Yeah.
in endo, right? Like go somewhere else where you're not
Right.
harming people with your judgment.
Right. Well, I had a podcast recently. His name's Aaron Washburn, and he has this thing called because his mother was a nurse and she died during COVID. And so he got touched by because he didn't know what we did, but he created this class called Empathy Prescription.
Mhm.
How see what was it? Mastering your emotions as nurses.
Cool.
He's trying to help nurses from burnout and stuff. So that's what I'm working on as well.
I love
All right.
it.
So what are the surefire signs in the ED that a nurse should be looking for concerning OB emergencies? Like if you had one OB emergency that you want us to focus on,
Yeah.
things that you don't want us to miss.
Yeah. Preeclampsia.
Right.
Pay attention to blood pressure. All right.
Preeclampsia and blood pressure. That's what I learned. Yeah.
Yeah. Really pay attention to blood pressure because the threshold for problematic blood pressure in a person who's pregnant or recently pregnant is 140,
Right.
right?
And that's crazy, huh?
And so you have to ask. You have to ask people is as it's appropriate, right? Do you yell it across the room? Hey, are you pregnant? No, you don't, right? But at the appropriate time, really
Right.
verify because people also, depending on where you are, and this goes back to this idea of these abortion bans and obstetric deserts, people don't want to disclose
Right.
necessarily that they're pregnant or have recently been pregnant. So
Right.
do everybody a goddamn favor and ask them privately.
So does it when you talk about blood pressure and preeclampsia, it doesn't just have to mean you're pregnant, but it could mean that you've already delivered. But how far out could it go
It's six
potentially?
weeks. It's 6 weeks is kind of the the outer edge,
Outer
right?
edge, okay.
But other complications like cardiomyopathy and PE can really persist like later in the postpartum course. So
Even as far as 12 weeks.
far as 12 weeks. Yeah.
Yeah, see, but people don't believe that. All right,
Yeah.
so I'm going to ask you a controversial question because, this is a big topic for people.
Okay.
How has COVID-19 pandemic affected the procedures about OB emergencies in the ED, and what changes have you seen since COVID and that
Oh,
disaster?
interesting. I don't, I know. Well, okay. So we know right now, 4 years later, as more and more information comes out, that COVID is a disease of vasculature, right? And so pregnancy, which is a hypercoagulable state
Right,
anyway, as is COVID, means that your pregnant patients are at really high risk for DVTs and PEs and strokes and all
right.
kinds of stuff that's clotting. Hang on one second.
No, you're good.
There you go.
I see
Oh,
that black cat. That's a big black cat, Doc.
I know it's a crying big black
Now,
cat.
don't be mad at me, but I was thinking about you live in Massachusetts and you got a black cat. I was like, hmm.
Hmm.
See, he thought that was funny. I know, but I love black cats. It's like no joke. I love black cats. It's like my favorite thing. Every time a black cat runs across, I'm like, oh, I'm gonna have a good day.
Yeah.
I do. It brings me luck. I like 13. Oh, that's good.
So so that would be the big thing. Really, with COVID is that the combination of COVID and pregnancy is like really high risk for so anybody who comes in with a recent COVID infection who's also pregnant and short of breath, like
Right.
scare the crap out of them,
All
right?
right.
Go
You
look
mean
at the
like
vascular
ultrasound?
leak.
Yeah, but ultrasound CT? Would you
Yep.
do a CT? You're not worried about,
It depends. Depends on where they are in their pregnancy.
right?
It's a cost benefit analysis, right?
Okay.
And that's not, necessarily a nursing decision, but it's a nursing conversation.
Well, you're the first person I've heard, and I don't know, maybe I'm just ignorant and I didn't read about it, but you said COVID, we know that COVID is a vasculature issue.
Yeah.
So is that why people are saying they're having like SVT or
Yeah.
cardio, I can't say it. Like,
Carditis.
yeah,
Yeah.
thank you, pericarditis and things like that. Is that the
That's part of
relationship
it.
to it? All right.
Yeah. I mean, so this is where we're seeing, like, this is why people have different manifestations, right? So some people have pulmonary, some people have neurologic, some people have GI, right? It's all because it attacks endothelium, right? And so so it becomes not just the flu, right? It becomes
Right.
a persistent problem for people. Um,
And then on
and
top of that, their comorbidities, diabetes, things like that, just aggravated and
age, the whole, yeah,
exacerbated. Yeah,
immunosuppression, like the whole, it's a shit show, man. Like, I still
right.
don't even go grocery shopping without a mask. So I
Well,
don't want that.
no, I know, but I say, I probably get in trouble. But the kids at work, I call them kids because I'm older, and so I come in, I wear a mask all the time, and then so I had a patient the other day. She was she was like 71, still working, a little heavy set, and I asked her, "Ma'am, have you been around anybody cold with cold?" But no, I had chested last week, but I still have my mask on, and I made her wear a mask.
Mhm.
Sure shit, she was COVID positive, and I come back, see, you lied to me.
Yeah, there
But
you
you
go.
never know. And
You
so I
never
always
know.
want to try to protect myself too, because I have my mother-in-law and father-in-law live with me, and they're in their 90s, and I
Right.
don't want them to suffer. Yeah, my
Exactly
father-in-law
right.
is 95, my mother-in-law is 80. He's still walking and talking. I take care of him.
It's good.
All right. So can you share any safety procedures that you have devised or learned over the years for emergency nurses, especially in handling OB patients?
Um, I think high index of suspicion, right? Always. Like you never want to start with, oh, they're fine and work your way up.
Right.
I think being really mindful when patients say they are bleeding, like weigh those pads, weigh
Right.
those chucks, right? Like really get a sense of estimated blood loss. Your patient comes in and they're bleeding and tacky, right? Get that fixed, right? And I think there's a really challenging overlap here. One is that you're talking about women for the most
Right.
part, and women, nobody takes women's complaints seriously to start
Right.
with,
Right.
right?
Right.
Women's pain, women's, complaints of fatigue, shortness of breath. Oh, it's all psychological, right? Listen to people. They are not making it up. I think
Right.
like that. I want to put that on a t-shirt. Like nobody's trying to fool you for their
Right.
own benefit, right? Like just
But,
listen to
but but
them.
why are we so jaded why are we so jaded though how come we don't listen to people?
I have no idea. I think that is cultural in the ED,
Mm,
right? Like nobody really needs to be here. Of
right.
course they do. That's why we're here,
Yeah, I
right?
just wanted to come into ED at 2 o'clock in the morning just
Right?
because I
Nobody
was
comes in
lonely
for
at home.
date night. Nobody, brings four snotty little kids to the ED
Right.
just because they had nothing better to do. Like, come on.
Yeah.
So yeah.
Okay, but I'm gonna ask you this because you're female. Why do women wait so long to come into the ED? You know, you're half dead, you got 10 hours post
Yeah.
stroke. You're like, I need help. I'm like, where were you a long time ago? Why do
Right.
women
Well,
wait?
what was I doing? Like, I'm the sort of person, like, at one point in my life, not now, but a few years ago, I would have, like, before I put my head in the oven, I would have done all the laundry, folded it, put it away, and
Right.
packed everyone's lunch for the next day, right?
It's
Again, this
true.
is a very cultural thing for women to ignore their own needs, right? Like women, and for this idea that women are weak or whatever, like women have an
Women aren't
incredibly
weak.
high
Right.
threshold for pain
Yes.
and discomfort, right?
It's true
Uh,
though.
and so yeah, they go when there's no other option.
But is it cultural? I mean, I'm
Yeah,
not saying it's not cultural. Is it cultural or is it innate?
no,
Is it
it's
just
cultural.
is it
It's
because
cultural.
women are built to be mothers, and because you're built to be mothers, like you take care of everybody but yourself, because I don't
Yeah,
need to
we're
take care of
culturally
myself.
conditioned to do that. That
You think
doesn't change.
so?
You're not born with that
All
software.
right, all right. I'm just asking because you see it so much, but I've never been able to stay. I've been to other countries and I've lived in other countries, but no matter where I've been, women still tend to be the housemakers and the caretakers
Yeah, viva la
and
patriarchy. Like
women
that,
out. I
that's
know, but women
patriarchy,
outnumber,
my dude. That's not biology.
but women outnumber men. So how come you haven't taken over?
Well, because we're afraid men will kill us. You'll notice that, like,
Mhm.
Margaret Atwood has this great quote that says, men are afraid that women will laugh at them. Women are
Oh,
afraid men will kill them.
I got you. All right, all right. Fair enough. I got you. But you know you could do that to us in our sleep, right?
Yeah, yeah. But see, we've got all these Republican governors that are trying to kill us.
I know. I
So,
got you. I'm with you.
the
I
message is
know.
clear. The
Yeah,
message is
it's
clear.
crazy, right? Yeah. I feel like I'm living in another world. So, all
Yeah.
right. So, what are your? I know we're almost up, but what are your? I'll ask one last question. Let me see, because I know you got to go. What kind of collaborations do you engage in with other stakeholders, hospitals, nursing schools, government that can help facilitate positive patient outcomes?
Yeah. I think that we currently I do a lot of work with external entities, right? So A1, ACOG, ACEP. I work with the Coalition on Psychiatric Emergencies. We
Oh,
work with, all kinds of people for whom the ED is the overlap,
right,
right? And I think what we really need to start doing in addition to that is partnering with administration groups, right?
right,
To remind nurse leaders and hospital administrators that their hospitals don't run without nurses. Like people
Right.
get admitted to the hospital for nursing care, not for
Right.
doctor care. And
Right.
so,
Do you think they forget where they came from?
yeah, I think they do.
How
I
do we
think they
help
do because they
remind
take
them?
all that unresolved trauma, run away from
Oh,
the bedside, but they take it up to the C-suite. And
mm,
so
I
managing
like that.
anybody else's trauma is entirely too painful, and they're not going to do it, right? So
Do you think they just don't give a shit?
I don't know.
Or do you think, like
I
you said, they
cannot.
just got so much trauma they just hide and don't want to deal with it anymore?
I think they'd shift their focus. Like I think there's a lot of compensation going on, but since I cannot be in their
Oh,
heads, I could not
no,
say
I
for
know that, I
sure.
know. But I think that's one to me, a conflict of interest. I don't think managers and directors should get bonuses by keeping the supplies down on your floor because they focus on money instead of focus on patient care. That I
Right.
don't like. That's one thing I would change. Yeah, all right. Now
I
you
agree.
brought up a touchy subject, psych nursing. Are you
Yeah.
working on anything psych wise through the
Yeah. We're
ENA?
working on
Because we
a
suck at psych patients.
Yeah, well, I'm working with, again, this Coalition on Psychiatric Emergencies, which is ENA, ACEP, APA, emergency psychiatry, like all kinds of people, looking at a way to set up almost like an algorithm or a flow chart. There's a lot
Right,
of different places in the trajectory of a behavioral health patient coming into the ED where um, where things can be mitigated or managed, right? Like the first, think about like somebody gets brought in either by law enforcement or by EMS, you've already like escalated them
right,
for the most part, right? Like,
right,
is there a place there that we can do better, right? Is there a
right,
place the when you talk about like people, especially emergency nurses being like really jaded and judgy and all that kind of stuff, right? If you treat a behavioral health patient like they're there to just piss you off,
right. You've already
that's
lost.
you've already lost, right?
Right,
Like just help them stop trying to control behavior, right?
right.
Stop trying to control people. We are all control freaks.
We are.
And trying to manage the behavior of people who are in crisis in the chaotic environment of the ED is just stupid,
Right.
right?
Well, we don't have the experience or knowledge on how to manage that behavior.
It's another thing.
We're not
60%
psych
of
nurses,
nurses
so
have
yeah,
no education post licensure
right.
on behavioral health,
But we
right?
should.
So these, and the fact that people see behavioral health patients as like they don't belong here, they're not really an emergency. And the thing is, if you've ever known someone who's had a behavioral health crisis, like they are suffering in the
Right,
same way that someone having a heart attack is
right.
suffering, right? So like get it together and go get some therapy, everybody, if you really
But
can't manage
but
a
I think that
behavioral
it's
health
because we don't understand it and we don't have training that we don't know how to treat it like a regular,
right.
heart
It's a regular
attack or things
emergency.
like that. Right.
Yeah,
Yeah. All right.
exactly. So more
Good.
education there,
All
certainly.
right. That's good.
So we want to put together this, process by which we can, and we do actually, we're going to do another pre-session at the ENA conference in Vegas on boarding. How do you
All right.
manage
Yeah.
how do you minimize, mitigate, and manage boarding
W-
behavioral health patients?
Are you going to create a class like the OB class for psych
That
training?
is not my job, but I can certainly
No, but I mean,
advocate for the
are
need for
we,
that.
is that, I know it's not your job, but is the ENA, do you think the ENA is going to plan on something like
I
that
don't
that
know.
will
I
help
think there's some talk about it, but more to come. I guess more
put a
work.
word in their ear?
Yeah.
Yeah, it's good. Well, I appreciate you taking your time. Is there anything else you'd like to share before we go? And I know I kept you over a little bit, but I really appreciate your time. I thank you for what you did. Yeah, that's nice. That's nice today. Give him a hug for me.
I know. I will.
That's nice though. It's nice though. It's good to have be taken care of though.
I know.
Yeah. So my wife's still home in bed. I don't get no tea.
Well, it's 6 in the morning. It's 7 in the morning where you are. It's 10 o'clock here. So.
Uh, is there anything else though you'd like to share before we depart? I really do appreciate you taking time. I don't know. I know you don't believe this, but I'm like a little schoolgirl giddy and stuff because I got to be with you. I love it though, because you didn't have to take your time. I know you're way up there. Most people don't know this, but you are a very important person, especially in emergency nursing. Yes, you are. Don't lie. I know you don't like that, but it's true. But I appreciate you.
It's weird. So
I know.
it's weird. So if I had anything to like use this platform, I would say like this is a really great job, but it is not your job to judge people. Like it's your job
Right.
to take care of people. Like somebody told me when I was first starting out, you need to love your patients. You don't need to take them home, but you need to
Right.
take care of them while you're
Yeah,
there.
that's
And
right.
so that's what you should do.
I appreciate that because I do. I sing to them, I hug them, I kiss them, and people think I'm crazy. But I do. I love it. It makes them feel good. There's nobody there loving them. So what that's our job. So
Nope.
all right, Doc, I appreciate you. I hope you have a great day. Have a good weekend.
Sure.
And I don't know who it was, but give her a hug and a kiss. And thank you for letting her come and see me on the weekend. Mhm. All right, Doc, you have a great day.
All right. See you later.
All right. Thank you. I appreciate you.
Don't miss out. Engage with us weekly, share your thoughts, and let's transform the nursing landscape together.